Cirrhosis is actually a pathological diagnosis. It occurs when the patient has sustained liver cell damage and the liver cells that are damaged are replaced by scar tissue. When the scar tissues are sufficient to encircle islands of liver cells, that's the state that we call cirrhosis. So patients with cirrhosis, when we biopsy the liver, we can actually see all these bands of scar tissue encircling islands of liver cells. And because the architecture of the liver is distorted, it causes obstruction to the blood flow through the liver, and that condition is known as portal hypertension. And the presence of portal hypertension is associated with a lot of complications. The presence of cirrhosis with portal hypertension at the beginning is relatively asymptomatic. So the obstruction to portal flow will cause blood to be diverted elsewhere. Now, as long as the remaining liver cells are healthy and they can do the job of the liver, then usually the patient is totally asymptomatic and will have no complications. We call that disease state compensated cirrhosis. However, when the pressure within the liver or the portal pressure reaches a certain critical level, we call that clinically significant portal hypertension, then they're going to develop complications. One of the major complications is blood being diverted from the abdominal blood vessels to blood vessels elsewhere, such as the blood vessels within the esophagus. They form varicose veins. And when the varicose veins reach a certain size, then they can burst. And that condition is known as variceal bleeding. So that is one form of decompensation. And another common form of decompensation is when patients develop fluid collection in the abdomen known as ascites. It's because when the blood coming in from the abdomen to the liver cannot pass through easily, the water part of the blood is being forced out of the liver, drips out from the surface of the liver into the abdominal cavity, and that is known as ascites. So the two major complications of cirrhosis are variceal bleeding and ascites. When either of these complications occurs, the patient is said to have decompensated cirrhosis. And compensated cirrhosis can exist for about 10 years before they decompensate. A patient with stable decompensated cirrhosis is somebody who has decompensated, say someone who has bled but the bleeding has stopped and the patient is undergoing treatment to prevent further bleeding episodes, or someone whose fluid retention, ascites, it's stable, it just gets drained on a regular basis and the patient does not have further complications. So that is a stable decompensated cirrhotic patient. An unstable decompensated cirrhotic patient is someone, for example, who's got ascites, who gets a new event. For example, the fluid in the abdomen becomes infected. And when that happens, then there may be other extrahepatic organs that stop functioning. So such a patient is an unstable decompensated cirrhotic patient. ACLF is a particular condition when a stable decompensated cirrhotic patient gets an acute insult and therefore becomes unstable. And the particular condition known as acute-on-chronic liver failure is when you have organs that fail to function. So an unstable decompensated cirrhotic patients have got a trigger, but the organs are continuing to function. ACLF is when the patient gets a trigger, but then you have other organs that start to fail. And the organs that can fail can be the brain, the kidneys, clotting cascade, and cardiovascular stability and lung function. Well, we actually need the treating clinician to be on the lookout in patients with unstable decompensated cirrhosis. They usually come in, they get admitted, something has happened. So either the patient has had an infection of something, or the patient has taken a large amount of alcohol and it's sustaining major liver cell damage, or the patient has taken some drugs that the patient is allergic to and sustained liver cell damage, or the patient has another bleed. All of these events place the patient from a stable condition into an unstable condition. And say, for example, if someone has a bleed, loses a lot of blood volume, then the circulation will shut down. And when that happens, you may get kidney failure from the kidney circulation shutting down, or you may not be able to maintain the blood pressure, and so the circulation shuts down. So in that situation, that's acute-on-chronic liver failure with organ failure. Once these organ failures occur, we do have treatment options. For example, in patients with brain failure, we can actually give them a drug called lactulose that will clean out all the toxins that cause the hepatic encephalopathy, which is brain failure. In patients who have got circulatory failure, we have drugs such as vasoconstrictors that will support the blood pressure. For patients who are in kidney failure, we also have what we call splenic vasoconstrictors. These are drugs that will squeeze the blood out from the abdominal vessels into the general circulation and into the kidneys to make them work. And so, yes, we do have treatment for individual organ failures. However, what we don't have drugs for is what is driving all these organs to fail. Now, in somebody who has stable decompensated cirrhosis and they suddenly get an acute insult, for example, like infection, there's a lot of inflammation going on. And a lot of these inflammatory markers are what mediates the other organs to fail. So basically what we're doing is that we're waiting for the organs to fail before we treat them. But it would have been much better if we can find something that can prevent the organ from failing in somebody who is going from a stable to an unstable condition. Inflammation occurs when you have liver cell death. So, for example, in a patient who has bacterial infection, the bacteria themselves can attract a lot of the inflammatory markers, and the inflammatory markers can cause what we call oxidative stress. That is, it makes the cells not function properly, and the cells effectively are starved of oxygen, and so you may have cell death in other organs. This is particularly true in the kidneys. When you have a lot of oxidative stress, then the cells are starved of oxygen. The renal tubules actually undergo cell death as well, and that's also contributing to organ failure. So it would be good if we can block off the inflammatory process and therefore preventing the cascade of further cell death in other organs. The more the inflammation, the higher is the oxidative stress, the higher the risk for multi-organ failure. And when you add on top of that, in all of these patients, when you have a lot of inflammation, they actually undergo a state of what we call vasodilatation. Hopefully, if we can stop the inflammation at the source, then we can prevent the progression of the multi-organ failure. Treating decompensated cirrhosis is a lot easier because none of the organs is failing. So, for example, in someone who's decompensated with variceal bleeding, then we have ways and means to eradicate the varices. In someone who's decompensated with ascites, we have means to clear the ascites, whether by large volume paracentesis or using a tip shunt to reduce the portal hypertension. And so they are usually not in a life-threatening situation. However, in patients with ACLF, usually they have organ failure, and you need to do your very best to prevent permanent damage to the various organs. Hepatorenal syndrome is kidney failure, and when it occurs, it's usually due to a combination of the renal circulation being totally underfilled and also the presence of various inflammatory markers that may also be contributing to cell death in the renal tubules. So the treatment that we have is a splenic vasoconstrictor that will increase the perfusion of the kidneys, and so the filtration of the kidneys will be better. At the same time, we also use albumin, and one of its functions is to mop up a lot of the inflammatory markers and thereby reducing the amount of inflammation and potential cell damage. Well, I'm hoping that we can find something that can deal with the inflammation in these patients, and also find some way of predicting which patient is more likely to develop ACLF when a trigger comes along. Now, at the moment, say a trigger such as infection that comes along, not every patient will develop ACLF. Some will develop organ failure, some won't. So I would like to see the research to figure out what patient characteristics would tell us that the patient is likely to develop ACLF, and in those patients, what preventive measures we can use, say for example, drugs to mop up all the inflammatory markers, or drugs that can prevent the inflammatory markers from reaching the target organs. I think industry is now recognizing that ACLF is a serious condition and potentially associated with high mortality, and therefore I believe that the industry is trying to understand the pathophysiology of ACLF, and thereby by understanding it, develop molecules that can prevent the cascade of inflammation and cell damage. The etiology of cirrhosis is different in different parts of the world. For example, in Asia, viral hepatitis, especially hepatitis B, is very prevalent. And so these patients may develop acute-on-chronic liver failure as a result of a flare of the viral hepatitis. And when that happens, most of the organ damage is within the liver. And so they will go into severe liver failure and maybe coagulation failure without having a lot of renal failure. However, in the West, where the bulk of the patients with cirrhosis have alcohol as the underlying etiology, and so they usually have much denser cirrhosis, and they usually have infection as a trigger, and so the pattern of ACLF is different. They are more likely to get renal failure, they're more likely to get hepatic encephalopathy or brain failure.